Okay, this is module 2.1, leg pain. HPI 80-year-old female presents with left leg pain, times 3 days. Pain is sharp, 10 out of 10, radiates from calf to hip, worse with walking, better with rest, is associated with redness and swelling. Patient denies any fever or trauma. Past medical history of diabetes and hypertension, dementia. Past surgical history, right hip arthroplasty, which was last week. Social history, patient is a smoker times 30 years. Medications, patients on insulin for diabetes and Toprol XL for hypertension. Review of systems, denies shortness of breath, chest pain, all others normal except for HPI. Physical exam, patient's vital signs are 110 tachycardic, 180/90 hypertensive. Respirations are 16 and regular. Patient satting 99% on room air. Temp is 37.5. General exam, patient's alert, awake, oriented times 3 and no distress. HEENT, pupils are 5+ reactive and oropharynx is clear. Neck is supple with no lymphadenopathy. Heart is tachycardic. Patient has a murmur, 2 out of 6. Lungs are diminished bilateral. There's wheezing in the right lower lobe. Abdomen is soft, non-tender, non-distended. Neurological exam, patient has no focal deficits. Extremity exam, obviously the most important part of this case, left leg of this patient, which she's complaining of the pain, is 4+ edema to the knee, warm, red, and tender to palpation. Right leg, there's 1+ edema to the knee. There's no warmth, redness, and this is not tender to palpation. Patient has good pulses bilateral, which is your dorsalis pedis or your DP pulse, and your posterior tibial pulse. This particular slide goes over how we are palpating pulses. The first demonstration is your posterior tibial pulse. This is on the great toe side, and this is right at the medial malleolus. The second demonstration is the dorsalis pedis pulse, and in this patient, this pulse is being palpated between the first and second digit, just proximal to that. This slide is a demonstration of what clinically we see when we're dealing with DVTs. You can see that the right leg of this patient, which is obviously in medical terminology on the left side of the screen, the right leg is, I would describe this as 3+ edema. Looks like there's some erythema on the anterior surface of the leg, compared to the left leg where you're able to see the delineation of the tibia. I'd call this 0 as far as edema or no edema, and there's no erythema. So there's definite asymmetry to these limbs, which would clue us in for the diagnosis of possible DVT. Another example of asymmetry of the limbs, the right limb obviously has marked edema compared to the left. That's 4+ edema on the right, possibly 2+ edema on the left. So there's definite asymmetry, and there's some erythema that you can see also on the right leg. So this also would clue us in that there may be an underlying DVT or some sort of inflammatory process or infectious process in the right leg. So this slide, this is a demonstration of pitting edema when we are able to palpate the anterior compartment of the tibia. As we press down into the tissue and release, you can see on the slide on the right where the fingers were moved, the indentation. That's how we are able to delineate whether it's 1+, 2+, 3+, or 4+ leg edema. So labs, white blood cell count, again, will come up in every lecture, looking for any sort of non-specific inflammatory infectious marker. Our D-dimer, again, a point of controversy with every physician. D-dimer and Wells score should always be documented if a venous Doppler is ordered. We'll go over Wells score shortly, but this is an indicator of protein and clot breakdown. That's what the D-dimer means. So if there's any suspicion of thrombosis or clot, a D-dimer non-specifically can tell you if it's elevated and the patient's at risk. When we do the Wells score, could be at high risk for a blood clot. So it's an indicator of protein and clot breakdown. Labs also, urine, we're looking for protein in patients that have leg swelling or leg pain that are pregnant. Protein in the urine can be an indicator of preeclampsia. BNPs are mainly drawn in order to assess the fluid retention in a patient. So if they have peripheral edema or swelling and pain, a BNP can clue us into how much they're actually centrally retaining. A BMP, or basic metabolic profile or panel, renal function is very important off this particular test in order to assess the BUN creatinine and see how the kidneys are filtering, and if the patient's in kidney failure, which could be causing the retention of fluid. Another lab that I did not include would be a TSH or free T4 and thyroid studies, because when patients have thyroid discrepancies, whether mainly it's hypothyroid, patient will have could present with leg pain and leg swelling. Mostly in that situation, it'd be bilateral swelling though. Okay, so here's the Wells score. So when we are assessing a patient, and if they need a venous Doppler or ultrasound, we would pair the D-dimer with the Wells score. So if the patient physician asks you to document a Wells score, this is exactly what we are calculating. So going down the list, if there's active cancer, which is treatments ongoing within 6 months, or palliative, patient scores a 1. Paralysis, paresis, or recent plaster immobilization of the lower extremity, patient gets a 1. Recently bedridden over 3 days, or major surgery within 12 weeks requiring general or regional anesthesia, patient scores a 1. Localized tenderness along the distribution of the deep venous system, a 1. Entire leg swollen, calf swelling 3 centimeters larger than the asymptomatic side, pitting edema confined to the symptomatic leg, collateral superficial veins, non-varicose. Very difficult to assess that particular score. Previously documented DVT, and if an alternative diagnosis is at least as likely as a DVT, you get a -2. So any score over 2 makes a DVT likely. A DVT unlikely is 1 or less. So in our patient, in our HPI, patient active cancer, no. Paralysis, paresis, or recent immobilization, no. Recently bedridden over 3 days or major surgery within 12 weeks requiring general or regional anesthesia, yes, she just had hip surgery, so she gets a 1. Localized tenderness along the deep venous system, yes, so she's at a 2. Entire leg swollen, no, it was the entire leg, it went actually up to the knee, so she's still at a 2. Calf swelling 3 centimeters larger than the asymptomatic side, I'd give her a 1 with her history and our physical that we had. Pitting edema confined to symptomatic leg, I'd give her another 1, so she's up to 4. Collateral veins, again, we can't really assess that. Previously documented DVT, no. Alternative diagnosis, at least as likely as DVT, no. So this patient would have a 4, so DVT would be likely with the Wells score. Pairing that with the D-dimer, if that is positive, this is definitely a case where patient needs a venous Doppler or ultrasound. So also when patients have leg pain, there's other issues besides the venous system, which is the blood that's traveling back from the leg to the heart. we need to assess for arterial clots or the blood flow down, and that's why we palpate pulses such as the DP and PT pulse. These are the 5 P's of arterial clots. There's pallor, which is lack of color, basically a white complexion to the extremity. Paresthesias, which is numbness and tingling to the extremity. Pain. Pulselessness, which is why we assess those pulses again. And paralysis, the patient's unable to move the leg when there's no blood flow. So pulseless and paralysis being two of the, obviously the last things that you see in patients presenting with arterial clots. So this is a surgical emergency when you have an arterial clot. DVTs can be treated with blood thinners, as we'll see with the treatment section. So moving on to radiology, we have the venous Doppler ultrasound, which again we use the D-dimer and the Wells score, which will be clearly documented in the patient's chart. Ask your physician. And this is where the patient has an ultrasound from the bottom of their calf all the way up to their femoral or their groin region. Arterial studies, these are ankle brachial indexes. They use these ratios between blood pressure cuffs in your upper extremity, which would be the brachial, and then blood pressure cuff down by your ankle, and they delineate the pressure difference and the gradient between the two to see if there's a flow problem, and that's how arterial studies are diagnosed with PVR, and that's just basically the waveforms that they do, assessing the arteries and the flow. We can also order a CT scan of the abdomen and pelvis with runoff, meaning that the flow that's down the aorta with the contrast, we will, the techs in CAT scan will make the abdomen and pelvis CAT scan drift down further into the extremities and the legs so they can see the runoff through the iliac vessels to see if there's any stoppage of flow of the contrast, indicating that there's a clot in the arterial section. So that mainly study is ordered by vascular. Our 2 studies that we get done from the emergency room would be venous Doppler arterial studies. Sometimes we go ahead and get the CAT scan with runoff if we're suspicious of a clot in the arterial system. However, we usually do this in conjunction with the vascular surgery team. So let's end with treatment. So for DVTs, we are dealing with heparin, which is obviously an IV blood thinner, which would require the patient to stay in the hospital, which they if they have a larger clot. Lovenox, which are shots, and then Xarelto, which is the newest form, which are pills that do not need monitoring, and I believe they're taken twice a day. In these situations with DVTs, there are a large amount of patients that we can discharge home in the right scenarios versus admission. So it's not unlikely that the patient will be going home with just the diagnosis of a DVT. Arterial insufficiency or arterial clots are a different story. These patients need stat vascular consults, means they don't have pulses, their leg is pale, they have extreme pain sometimes, and the flow down can lead to gangrene and loss of limb with the ischemia. So essentially the same thing that a stroke is to the brain or a myocardial infarction is to the heart, an arterial clot to the leg is the same situation. You can actually lose muscle, you can lose flow to that area, and you have significant damage which may end up in amputation. So blood thinners versus surgery is the treatment, and surgery being the most likely disposition if you're finding that the patient does not have pulses and they have arterial clots. Other situations with leg pain, cellulitis, antibiotics are warranted in the patient where they've already had prior treatment as an outpatient, they failed the oral antibiotics, they may require IV antibiotics and a short stay. Cellulitis cases that are very that definitely need admission would be circumferential, meaning it encompasses the entire leg from the anterior all the way around to the posterior surface. Those particular cellulitis cases will need IV antibiotics if they don't get better on their own with oral antibiotics. Peripheral edema is mainly the diagnosis of exclusion then. In these cases, we're dealing with getting the fluid off of the patient to make them comfortable, which Lasix or furosemide is the main diuretic in that case. And we also use Jope stockings or TED hose to compress down the area. And these modalities aren't to be used at night while the patient's sleeping, but just in the day when they're ambulating and have dependent gravity and fluid accumulating in their legs. So that concludes our Module 2.1 on leg pain.